If it's like right away, like you just go and do it, like this, like a lot of people.
We'll go ahead and get started. People can come in and they can catch up with the food. They're not going to miss anything all that exciting. So next pin is going to be 947864. All right. 947864. Nine, 4, 7, 8, 6, 4. Everybody in that's going to be on? No. Hey, who picked moose? All right.
Well, he's not here, so it wasn't him.
All right. There we go.
Mary.
We're nurses. We can do a 15-second hand wash and go to the bathroom in 60 seconds. All right. We'll go ahead and start. We're on diuretics, chapter 51. Yep, not chapter 51 for you guys. All right, so question. Thiazide diuretics are potassium sparing. True, false? 50-50 chance here. False. Your thiazide diuretics are their own class. They are thiazide diuretics. They are not your potassium-sparing diuretics, okay? Your potassium-sparing diuretics are more your triamterene or spirolactone is the one that we see most often. Okay? 2 more. Way to go, Laura. All right. Your patient with CHF complains of shortness of breath, respiratory rate 32, crackles throughout bilateral lungs. You anticipate giving. You guys read that back there? Red is osmotic diuretic PO. Blue is thiazide diuretic IV. Yellow is potassium-sparing diuretic IV. And green is loop diuretic IV. All right. Your loop diuretic IV is going to work most quickly. Your osmotic diuretics are actually only available IV, and are those used for CHF, fluid overload? No. Thiazide diuretic IV, and I'm not going to help you tons. I don't even know that they make potassium-sparing diuretics IV, truth be told. Your loop is most effective. Last one. Way to go, Maggie. Osmotic diuretics, oh, I didn't give you the answer, sorry. Require 22 micron inline filter for administration. Take a guess. Anybody hang it before? Minute 12. If I ask the question, it's actually true. Yeah, when you actually hang this, there are like crystals. It's thick. If you put a few drops on the ground, because you will when you're priming the line, you will see little crystalline drops around your scrubs all the time. So you do need a filter for mannitol, but that wasn't fair because that was my pharmacology class. You guys know that. Oh, I asked 8 questions. Holy cow. All right. Normal lab values of potassium. All right. Red is 1.5 to 2. Blue is 5.5 to 7. Yellow is
I do
Oh,
not.
good to go. All right. Green might be a correct answer, but it's not the most correct answer. All right. Megan, wow. Good job. I'm sorry, there's a whole 5 of 8. Okay. Spirolactone and lisinopril. You would be concerned if he states that he eats or uses chocolate, red wine, Swiss cheese, salt substitutes. Salt substitutes. I gave away the question by saying uses instead of eats. It's not an MAOI. We can still go ahead and use chocolate, red wine, and Swiss cheese. The salt substitutes are usually potassium-based, right? That's going to increase your potassium. Spirolactone, what kind of diuretic? Potassium sparing. And lisinopril, everything's bringing the potassium up there. Maggie? All right. Your patient is on a loop diuretic. Which sign and symptom would be a priority suggestive of potassium loss? Is it going to be hunger and fatigue, 4+ deep tendon reflexes, muscle weakness and cramping, or tall peaked T waves? Trick question. Muscle weakness and cramping. When do we see tall peaked T waves? Hyperkalemia. That's when your potassium level is starting to get 6.5, 6.7, 7.2. All right. Hunger and fatigue, signs and symptoms of hypoglycemia, among others. And 4+ deep tendon reflexes. All right. Oh, not gonna know. Let me skip it. Let's try. Well, okay, let me just tell you. FYI, NSAIDs can counteract or blunt the effects of your diuretics. So which NSAID is up there? Ibuprofen. Awesome. Yay, yellow. Way to go. Who got that one fastest? Okay. Last one. Oh. Which sign and symptom would suggest ototoxicity and would be a concern with the patient on a high ceiling, aka loop diuretic? Which one of those is suggestive of ototoxicity? Can you guys read okay? I'm sorry. Photophobia, tinnitus. Oh, there we go. The correct answer is tinnitus. Okay.
I like the arachnophobia.
I actually had a whole bunch of people in my pharm class answer arachnophobia.
Because I would be screaming very loud.
All right, so tinnitus. You need your patient to report tinnitus. And our loop diuretics, not our thiazide, but our loop could have some ototoxicity there, okay? Is that the end? All right. Who's Ellie? And Ellie.
Ellie.
Who is L-E? Okay. Way to go, L-E. And who is Ellie? All right.
Oh, sorry, I was looking at
And then who was Christy? Who's Christy?
Thank you.
All right. Now we'll jump into our anti-blood clotters. What do you do overall? There you go. Oh. All right. Thrombolytics. They used to use thrombolytics a lot more way back when, before we had cath labs available in every hospital. If somebody came in with an acute MI, we would give them a thrombolytic because we did not have the capability to go in and do an angioplasty of percutaneous. We just didn't have it. We might still use our thrombolytics for acute DVT or PE sometimes. We want to do it for an ischemic stroke. Do we want to use thrombolytics for a hemorrhagic stroke?
No.
Thank you. Thank you. Most often I see it using declotting your central line, your PICC line that's gotten, so that's when we're going to go ahead and break these out. So this is our TPA, our streptokinase, alteplase, urokinase. Again, we'll see it in peripheral vascular disease, peripheral arterial disease. Sometimes we can infuse through certain lines. We make the poor patients stay in the ICU, literally with a femoral line going down into the artery of issue. And slowly infuse TPA over a period of time, usually urokinase. Your biggest side effect is bleeding. Yeah.
So like the central line clotting, besides not getting any push or pullback, that just how you know it's clotted, or
Yes.
you don't do like an ultrasound or anything?
No, literally, if you're not getting blood flow from that line, it is clotted somewhere. Something is going on that's probably not going very well. Okay, you should be able to pull blood from your central line.
Because they tell us just to stop. That's what they fall.
Yeah. No, you should be able to get blood. If you don't, off you go. Then you're going to contact your prescriber and look at the order. All right, so bleeding. If a patient has an ischemic stroke, we have certain criteria that have to be met in order to be able to give a thrombolytic. Do you guys know what those criteria are? 3 hours, although they've actually extended it a little bit now, we'll say even 6 hours, okay? But the gold standard always used to be they have to present to the ER, you have to get this going within 3 hours of onset of symptoms of your ischemic stroke. Again, now we're kind of extending that out even a little bit more, okay? Yeah, we're going to get them in for an immediate CT. Most places now have your stroke alert or your whatever other alert they want to call it to get them in as fast as possible. If their blood pressure is 200 over 100, do we want to use a thrombolytic? No. Too much to trans. Again, the big risk here is bleeding, and that's a dangerous and or deadly side effect, especially if we have now converted an ischemic stroke into a hemorrhagic using an overly powerful blood thinner. Okay. If your patient is on a blood thinner, again, this is not the time to be giving any IMs, right? It's not even the time to necessarily be trying to do IV sticks, and unfortunately learned this one the hard way in the ICU, where a patient was on a thrombolytic. She had already lost 2 and part of a third limb. They were trying to, no, it was the third limb that they were trying to save. They were trying to restore blood flow through it, had to start another IV line in the ER. They tried multiple sticks and ended up with severe bleeding and compartment syndrome in that forearm. Not a good day. So, side effect, bleeding. These patients are in the ICU. Unless you're declotting a line, and that's not really exciting. So antiplatelets, this is when we're thinking of like our Plavix, even our low-dose aspirin, although NSAID has our antiplatelets properties, right? So that's why your patient who is on 81 milligrams a day, are they taking that for pain or fever? No, that was always my biggest pet peeve. They're using it for antiplatelet properties, okay? So we're going to use it for acute MI, ischemic stroke, PE, DVT, all right? So if your patient is scheduled for surgery, usually how long in advance are we going to stop these? 5 to 7 days, absolutely. All right. If your patient has had an MI, how long will they be on the antiplatelets? Aspirin is going to be like forever. Your Plavix or something like that is at least a year, maybe more. Okay. If they have stents placed, the same thing, because the stents are a foreign object to the body, right? Anytime the body kind of sees something foreign, what are they going to try to do? Attack. You got it. Everybody did this move. Clump up. Yes, absolutely. Clump up and attack. All right. So clopidogrel is the Plavix that we think of. Side effects: bleeding and some GI upset. Anticoagulants, you're probably still going to have to know these. Good old warfarin, going to have to know it. Still used in practice, okay? So they're going to end in ferrin, such as warfarin, or heparin, such as heparin, enoxaparin, right? These are our blood thinners, okay? So what do? They work to help decrease clotting factors, okay? So they are used for MI, AFib, why do we want to anticoagulate somebody in AFib? Absolutely, because again, the atria is not contracting as well as it should be. And anytime the blood is stagnant, what happens? It clots. That's what it's supposed to do. All right? So, heparin and PEDVT, obviously. We're trying to help resolve that. And then we have our newer, they call them the novel anticoagulants, right? Everybody has seen the commercials for Xarelto. Okay? Now, ends in Zyban. Do you know why? It actually inhibits factor 10A. Okay? 10A band, inhibiting factor 10A. So Zyban. When you see that, those are your new novel anticoagulants. Okay? So for your anticoagulants for the older ones, we need to monitor our PT, our APTT, and our INR. Okay? Do you guys remember which one's which? So let's say we're on warfarin. What do we need to monitor? INR. Okay? For heparin, we want to monitor PTT. Okay? Our new novel anticoagulants, what do we monitor? Good answer. You're in the dark. You're in the dark. We're not titrating based on anything. And that's the thing, is that we don't have reversal agents yet that are FDA approved. They were supposed to approve something last September, and they sent it back for more research and testing. So for warfarin, what is your reversal agent? Vitamin K. Exactly. Because all warfarin does, originally designed as rat poison, all it does is it inhibits vitamin K synthesis. Okay. So warfarin, then we have to worry about diet with things such as what? Leafy greens, spinach, and anything else that has vitamin K. So when your patient starts on warfarin, Coumadin, it's kind of a big deal. There's a lot of dietary considerations that they have to learn about, okay? You're not going to tell them to never eat it again. You want them to eat the same amount that they usually eat. You don't want them to make any changes, right? We titrate the dose for what their body is doing, and then suddenly they decide to eat healthy and eat a whole bunch of salads on me. No. What else do I have there? And with all of these, especially our heparin, as you said, we have to monitor our platelets. Everybody familiar with heparin-induced thrombocytopenia, HIT, H-I-T? Is there anything else that I have to say there? I have a Kahoot. Remind me, we'll come back and do it later. What is our target INR if we are actively anticoagulating somebody?
2 to 3 times the normal.
Which is roughly?
Like 2 to 3.
2 to 3. Fair enough. Usually 2 to 3. And then if we're actively anticoagulating somebody on heparin, what do we want our PTT to be? Roughly.
40 to 67.
Maybe even a little bit higher, 50 to 70. Each place is going to have a different, you know what I mean? Good Sam, it's 55 to 75. Loyola, we're a little bit more risk-taking. We'll go 60 to 80. Sometimes it also depends on, are we using it for a PE or a DVT? Side effects: bleeding, hypotension, not so often. Hematuria, of course. Thrombocytopenia, especially with our heparin-based products, our low molecular weight heparin or our heparin. All right, and third track, antidepressants. Okay, you guys are fifth track, so you might have forgotten all about antidepressants, but they are used for depression, OCD, eating disorders. Some of them might even be used for chronic headaches, and that's usually our tricyclic antidepressants, our TCAs. I think we're kind of getting away from our TCAs now because they do tend to have a lot of side effects. Back in the day, they used to use MAOIs. We might have mentioned MAOIs in pharmacology. We don't really use them much anymore. And the last time that I did this presentation and I said them, I had a student say, wait, I work in mental health and I have one patient on it. Oh, God help us. MAOIs interact with everything. That's pretty much all you need to know about MAOIs. And you want to avoid certain types of foods, right? Tyramine. What happens if you take tyramine when you're taking an MAOI? Yep, that blood pressure is going to go a little nuts. So what else do I need to say about those? Again, I was still tested on MAOIs when I took the NCLEX. I'm hoping that now that's not going to be the case anymore.
They still test with all the foods.
Okay, so what kind of foods? Cheese, wine,
Is there like cured meat?
chocolate, pretty much anything that's good. Yeah, and cured meats, smoked meats, things such as that. What else do you need to know? What are some nursing considerations with your SSRIs? How long is it going to take to work?
6 weeks, 6, 8 weeks.
We might start seeing some changes in 3 weeks, but yeah, you might have to give a full 6 weeks, maybe even 8, until you are seeing true changes. All right. What else? Wait, you have your hand raised.
That's what I was going to say.
All right, nice try. Right here, just want sugar back there. It's the afternoon. You guys staying away? All right. What else? Yeah, you were going to say.
Are they at an increased risk for suicide?
They're at an increased risk for suicide. Do you guys know why?
There's like more energy. If it starts to build more energy.
Yeah. So there's a black box warning for our SSRIs, SRNIs that talk about a suicide risk. And this is really geared more towards our teenagers and our young adults. Okay? Here's the thing, is that those people, that group in general, has less impulse control than some of our older adults. Okay? So if you are so severely depressed, you have no energy, but you have a plan of how you're going to kill yourself, well, start you on your SSRI. Guess what? We've made you feel a little bit better, enough so that now you have energy to act out that plan, okay? It's not necessarily the antidepressant itself that is giving you these suicidal thoughts. Not usually the case. But again, we've now just given you a little bit more energy. So that is a black box warning for these. What else? Do you want to abruptly discontinue these? No. Bad idea. Absolutely bad idea. And then what about malignant hypothermia, hyperthermia? What is that?
That's when you take anesthetic. It's allergic to anesthetic.
We could potentially also see it with some SSRIs, but not. Okay. Dun, 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 dun. All right, benzos. These are going to end in Zepam or Zolem. So alprazolam, Xanax. Okay. These will depress our. Yeah.
I had a patient. I love patient. I had a patient the other day tell me that Xanax is actually pronounced Xanax.
Oh, good.
And then I was saying it wrong the whole entire time. And then also it's an opioid. And I was like, yeah, I just learned so much from you today. Like,
Was that the same one?
no, different guy.
So what do? They produce relaxation, right? They're going to produce a state of relaxation, okay? It's going to depress the central nervous system to produce relaxation, okay? So it can be used for anxiety and or tension, okay? Our Zepams can be used for muscle spasm. So diazepam, Valium, used for muscle spasm, okay? We can use them for acute ETOH withdrawal, okay? And preoperative, gonna help you relax a little bit. Sometimes we'll use these in twilight, right? Anybody of you observed in the GI lab? And you know we'll give that fentanyl Versed cocktail, twilight sedation. What else do we need to know about them?
I take it this is acute muscle spasms. It would be like for MS patients.
No.
They
No,
get like
not
baclofen.
Yeah, exactly. No, this is for acute, you know, hey, I threw my back out, you know, I'm going to take some Valium. Or I guess, I don't know, women in the 1950s or something. Yeah. What are some nursing considerations regarding these? Sedation, wait, who said that? What else?
They decrease your respirations, right?
They can decrease your respirations if taken in a significant amount, absolutely. What else do we need to know about them?
They're lowering blood pressure by reducing.
They could reduce tension, decrease the blood pressure slightly, absolutely. What else?
Maybe you have to monitor like the liver and
Of course. Definitely monitoring liver and kidney function. What else do we want to think about these?
Addiction and this.
Huge.
Do
Huge.
not mix with alcohol.
Thank you. Don't mix with alcohol. We will, with these medications, we will build tolerance. There is also the risk of dependence, and keep in mind those two are much different concepts. Okay. All right. So we need to watch for physical dependency. We're going to gradually taper them off if they've been on them for a while, and ideally we don't want them on them for a long period of time, right? Monitor liver and kidney function. Avoid tasks that require mental alertness. Do not pop 0.5 Xanax and go and take your NCLEX. I don't care how stressed you are. Watch for hypotension, sedation, visual, speech disturbances. And as you said, don't mix with alcohol, please. All right. Opioids. Not always. They don't always end in ON because some of our steroids do, so don't get too excited. But hydrocodone, right, or morphine. But again, keep in mind that is not a general rule, okay, because ONs can also be our steroids, all right? So used for acute pain, chronic pain, withdrawal sometimes we'll use them, and palliative care. So what nursing considerations do we need to worry about with constipation is huge. Let's go back to constipation for 1 second, because sometimes some of these things will also cause feelings of drowsiness. Typically, patients will get over that feeling of drowsiness, okay? Constipation is one of the adverse effects that will stick with you, so to speak. That one does not resolve, okay? That is going to continue to be an issue, okay? What else do we need to consider?
Respiration.
Respirations, please. Oh, that's a big deal. Yes, and your reversal agent is going to be Narcan. Right. What else do we need to know? I think we hit most of those. Oh, what else? GI, besides constipation. Nausea, vomiting. Oh, big time, big time, big time. If you work PACU, you will know that these poor people coming out, you're just there trying to get them to take sips of water, to urinate, and to make sure that you're there with a bucket if you need it, okay? Again, tolerance and dependence are two different things. This can cause both, but tolerance is just the body's way of maintaining that, guess what, you're going to need an increasingly larger dose to get the same effect. Tolerance does not equal dependence. Does that make sense? So again, I know that in the ICU when I'm dealing with acute pain, I start to sweat when I have somebody who's been on chronic pain medications for something such as cancer. You know, 2 milligrams of Dilaudid is a significant dose, FYI. Okay, 1 milligram is about equivalent to 8 milligrams of morphine, okay? So 2 milligrams is about 16 milligrams of morphine. In case you don't know, that's a lot. So, and somebody who's opioid naive, strongly question that order. You're not giving that to a 75-year-old little lady with ORIF, okay? But for some of our cancer, for our palliative care patients, these higher doses are normally what they take, and if we give them less, they're going to withdraw, right? So again, I start to sweat when somebody says push 10 milligrams of morphine. I go, oh. But Anne-Marie, with her cancer patients, what's the most you've ever given at a time?
200
Of morphine?
Yes.
200 milligrams of morphine an hour. Again, that gave me chills because that would make me very nervous about my nursing license. All right.
Was not on it.
Fair enough. What else do we need to know? I think that's it. I think that's it for our pain management medications. And again, remember, unfortunately or fortunately, pain is subjective. And boy, that's hard when your patient's like, my pain is 10 out of 10 texting in their bed, right? Because my version of pain 10 out of 10 is much different than, but, all right, it is what it is. You guys got all those. Oh, didn't mean it. There you go. So our non-steroidals are used for analgesic, antipruritic, and yeah, if it's aspirin, it's also an antiplatelet anticoagulant. Okay, so these are our Profen, ibuprofen, right, or our Fanac.
Maybe you can answer this question for me.
Maybe not.
Anticoagulant, why? Because they tell me,
Antiplatelet.
I understand them, but they also say that ibuprofen, you know, for GI upset and causes GI bleed and all that other stuff. Well, then why don't they give ibuprofen along with an aspirin or instead of an aspirin?
Not as well working and increased risk of renal damage. So again, if you want the antiplatelet qualities, you're going to use aspirin. Okay, you're still going to watch for your ototoxicity either way. Okay, but not as effective. It's going to be more effective for pain management. Do we give aspirin to children anymore?
No.
Why not?
Reyes syndrome.
Right? Right?
Reyes.
Anyway, we don't do it anymore. But back when I was a kid, we all had St. Joseph's aspirin for children. It was it was actually the biggest overdose of pediatrics back at that time that any of us lived. We didn't ride with bicycle helmets. I don't know. All right.
Well, there is one condition they give it for.
What?
There is one condition they give it for. And
Wait,
somebody-
strawberry tongue. Hold on. Kawasaki syndrome.
Yeah, Kawasaki.
Yeah.
Yeah. So
Was that
somebody in the other class is doing their SR on Kawasaki.
Yeah. That is the only time that we'll give some pretty high dose. That's not even just any joke. That's pretty high dose. But yeah, is it bad if I have to go by strawberry tongue first? Okay. So side effects, you guys probably know these. GI upset, definitely. Can these cause? Do we have to watch for peptic ulcer? Risk of bleeding, tinnitus, and I'm not worried about the bottom one. Okay. So this is our diclofenac, ibuprofen, things such as that. They work well. They do work well. And again, aspirin should be discontinued 5 to 7 days prior to surgery. Bronchodilators, okay, used for asthma, bronchitis, COPD, typically the form of emphysema, maybe chronic bronchitis as well. There's 2 different types of bronchodilators. We have our short-acting beta agonist, otherwise known as albuterol. Okay. Those typically work. How long does it take to work? Usually within 5 minutes, you're going to start to feel an effect. It might not peak for an hour or 2. Then we also have our long-acting beta agonists, right? These are going to usually utilize twice a day. It's not going to help you for an acute asthma attack, right? This is used for maintenance. If you have some pretty severe asthma, you're going to take your long-acting beta agonist, usually going to be given in a combination with an inhaled corticosteroids. What do steroids do?
Give you tremors.
Albuterol is usually the tremors. It decreases inflammation, okay? Inflammation specific in the lungs here, all right? Anytime that we used an inhaled corticosteroid, what do we need to do afterwards? Rinse your mouth. Awesome. Why? Thrush. Oh, easy. Easy, easy. So typically our beta agonists are working on beta 2, right? Which is where receptors are in the lungs. If we take too much of it, we can't see beta 1 effects though. Now keep in mind, too much of it for some people too much of it is like 2 puffs, you know. So some of us get tachycardic and tremors just with the normal dose of albuterol. Absolutely. What else do we need to say there? Other side effects besides tremor and tachycardia? Anyone? So like push the button moment. All right. Restlessness. Oh, if you have a pediatric patient with asthma, my son was 2 years old. This kid had to have nebs every 2 hours, day and night. That was the worst week of my life, by the way. This kid was bouncing off the walls. And it probably didn't help that I gave him gummy bears to keep him situated while he took them. Never mind. Restlessness, those kids will bounce off the walls. Maybe some hypertension. And if it's not beta 2 selective when we're using a lot of it, we just have to watch for cardiac arrhythmias. Okay. Yeah. Short-acting beta agonists make sure that your patients understand how to use the meter dose inhaler, or spacer is going to be better, especially if we're talking about a pediatric patient or a geriatric patient. Timing, they're going to end up with the stuff in the back of their throat instead of in their lungs. Our PPIs, do you guys remember PPIs? Pantoprazole, omeprazole, lansoprazole, Prilosec, Prevacid, Protonix. Next's in there too. Used for GERD, used for peptic ulcer, used for erosive esophagitis. What do we need to know with these?
So, they'll discontinue.
Don't discontinue immediately. How long is it going to take for these to work? Are you going to take a PPI of Protonix and feel better tomorrow? No. No. It could take actually 1 to 2 weeks even. It could take longer than that. All right. Do you want to crush or chew these? No. Sounds like a bad idea. No, it can increase your risk of C. diff. Because of blocking some calcium absorption, it could also increase your risk of osteoporosis. And most recently, within the past year or two, they're finding a link with dementia. Right. Woohoo! Yay! All right. Now, before I get into antibiotics, antivirals, antidiabetics, those are really, really high level. What you need to know about your antidiabetics is you need to know your insulins. You need to know when do they start, when do they peak, which ones can you mix? Oh, heaven forbid. For the most part, you guys, I probably only mixed insulin twice in my life, and that was probably for like a VA patient, okay? We're not doing cloudy, clear, clear, cloudy anymore, but will they still test you on it in Ectoplex?
Yes.
Yes, they will. Again, I can't even remember the last time I've had to do that. Do you guys want a Kahoot?
Yeah.
Okay. Which Kahoot do I have left? I don't think I still have. Which one were we coming back to?
Blood thinners.
Blood thinners. Okay. Chapter 48 Kahoot. There we go. All right. Are we ready?
Yeah.
Okay. Good. 375-472. I'll give you guys one more minute. All right, everybody in that's going to be in? Or do you need one more second? Okay. Looks like that. Oh, there we go. All right. Ready? Okay. Again, warfarin actually initially was developed as rat poison. Warfarin's onset of action usually occurs in 8 to 12 hours, lasts for 1 to 2 days. Uh-oh. Might have to make you think a little bit here. True, false? Just waiting for one more answer, I think. I like the music better. Okay. False. How long does it take, actually, for warfarin to... Oh, we were totally split there. Typically, we're going to start patients on warfarin and heparin at the same time. Heparin is short-acting. It's going to work right away, but we're using the heparin as a bridge to get the warfarin so that our INR gets to be to the level where we want it to be. We could take 3 to 5 days to get to therapeutic, hopefully only 3. So typically, bless you, we are using heparin at the same time that we initiate warfarin just to give anticoagulation protection until we finally get to what we want to be. Way to go, Laura. To determine the effectiveness of a patient receiving heparin, you want to monitor what? Is it going to be PT INR, activated PTT, or your hemoglobin. My name person is probably left out. You are going to want to monitor good. You're going to want to monitor your PTT or your activated PTT. Okay. INR is used for Coumadin and warfarin. Lowers Stolaracanine. Reversal agent for heparin. Is it vitamin K, FFP, protamine sulfate, or there is none? Protamine sulfate is your antidote. Wow, good job, you guys. Our novel anticoagulants are Zyban, that's where we have none. Oh, damn. Never mind. All right, so is it vitamin K, FFP, protamine sulfate, or is there none? Go green. There is none. I'm letting it go. I'm letting it go. All right. Patient is with AFib on warfarin. Target lab monitoring for anticoagulation effectiveness. Do we want to target our activated PTT to be 50 to 70, our INR to be 2 to 3, our BUN to be 7 to 20, or our TSH to be 0.5 to 4.5? Again, if they're on warfarin, aka Coumadin. INR. Awesome. I think that might be it. Is that all? Oh, one more. All right. Oh, thrombolytics treat patients who have suffered a CVA in the last month to help solve clot. True, false? False. What's the duration from the time that they have had a stroke until the time that we want to, 3 hours, maybe 6 if we're going wild. All right. I think that ends up your time. We did not get to a few of them. You can kind of review them on your own. If that doesn't work, during the lock-in, I have a pharmacology review for my students. Please know that you are always welcome to come join me in that. And then we also have our pharm tutoring on Thursday. You're always welcome. That's not just for pharm students anymore. You're welcome if you're not doing anything fun on a Thursday night. I think Thursday at 5:30. Hannah is our lead person who's doing the pharm tutoring. You are welcome to join her in there. Awesome.
All right. I don't think I have anything else for you guys. So if you have any questions for me about skills work or SR or anything, let me know.